working in the acute care part, we do this by ourselves. In rehab, in that particular setting, a lot of the techs have been trained to go ahead and go get their patients and bring them down to the exercise gym. So he has some prior experience on how to do this, and so does Pat and so forth. All right, so
No pressure.
all right, so go ahead.
All right, knock knock. How's it going? I'm Gabriel. I'm a student at the Physical Therapist Assistant Program at South University. How are you today? Pretty good. You okay? Have any pain or anything? Do you know what today is? Yeah, what's today? What's today?
Red flag.
Mild cognitive impairment.
It's 2 days off.
It's the 15th, tax day.
So do you know why you're here?
Was that yesterday?
Thank God she's pretty.
That's fine.
Do you know
I'm okay with it.
right side stroke? Okay.
Wow.
So your right side is your impaired side. Except for right stroke. Right.
So his left side is a parasite, guys, okay?
Okay.
Left side, okay.
Left side is what?
It's a parasite. So he's left-handed.
Talking too fast.
Alright, so pretty much I'm here because I'm going to get you out of bed and we have therapy. I want to get out of here.
I want to get out of here.
Alright, so I want to see how much you can do first before you get up. Can you move your toes for me? Okay. How about your arms?
So it's a whole nother mindset. So he's used to going into a patient's room right now and getting patients out of bed. But as now a therapist and a student, he's going to be looking at the patient more critically. So those of you who work in healthcare now with patients, you're going to be obviously attacking things a little differently, looking at more critical. Just go ahead and max incisions.
Alright, so what I'm going to have you do is, can you try and scoot over a little bit that way? Maybe a little bit.
This is what you guys will have to. You have to go to the other side of the bed. You'll have to scoot patients over. You'll really have to do quite a bit. What do you think?
Alright, so what I'm going to have you do is roll on your side, on this side, okay? Okay, when you can. I'll help you. Try to bend this leg. Drop your right leg. Now, with using your momentum, I'm going to have you come up and sit up here on the edge of the bed. So when you come up, get your leg point down through your feet. With this, I want you to try to push off of this one.
Pat, you're making me feel so sad for you.
I know.
I'm like,
He's doing good. He's a good
so
athlete.
Where were you at, Dave?
It's really hard to simulate this until you get in front of a real patient who doesn't have use of their limb. But basically, what Gabe's doing is he has to support the patient with one arm, basically, and being able to use his body and still be able to put that gait belt on. So this is something where when you go to hire on as a new therapist who just took your exam and you're working in a hospital, this is where you're not going to call another PT or PTA to help you. This is the skills that we expect you to come into entry level stuff. Yes.
If he has left hemiplegia or whatever, he would have a lot harder time like pushing him up because he wouldn't be able to like
100%.
trunk, bend his trunk at all.
He held, yeah, absolutely. That's what I'm saying. It's hard to really demonstrate exactly what happens. But if he's sitting like this, he's probably doing this. He's probably falling to one side. So he's, I'm saying, okay, hold yourself, and he's going to one side. So it's a lot of work for us to come in, and I have to basically take over the function of this left side. So there's a couple different ways to do it. Mike might have his technique where, you know, he sits on the edge of the bed like this with the patient, which is a very fine technique. So, you know, patient can put his hand here. So now, you know, you can work with the patient with shifting weight side to side. You know, he's holding here, lean forward with your right hand. So he's kind of weight shifting this way, and he's bearing weight here, or he could lean this way. There's a lot of things you can do in this position, but the reason why I did it with the left side is because there's a condition called hemi-neglect. And what that means is that your patient is really not paying attention to their left visual field, or they're not as much aware. So you as a therapist want to be, if you can, on this side. So when Pat looks straight ahead, he sees everything, you know, straight ahead to the right, but he's really not aware of everything to the left. So I'm like, you know, hey, Pat, look over at me, giving him auditory cues. I'm touching his arm, I'm pushing it to his leg, giving him tactile cues. This is going to make him pay attention to this side over here. He has flaccidity, so that means that if I were to grab his shoulder like this, it'll sublux. So then I can palpate the head of his humerus, come down, and I'll say, oh wow, there's 2 fingers. I can get my 2 fingers in there, so I know his rotator cuff is now working. So a couple of things I can do for therapy techniques is I could put his hand here, and now I can hold him, and as I lean him this way, he's getting compression or joint approximation, so that's going to help strengthen this affected involved side. Okay, so this is all the intervention you can do before you get a patient out of bed. A lot of therapists will say, okay, well, the doctor said they want the patient out of bed. Well, if Pat is a max assist to go from supine to sit, how are we going to go from sit to stand to a chair? That's where the dependent total lift might come in. So you have to know how to work with the patient in the sitting position. Okay. Now, when he goes to stand up, I know this leg is weak. So, if somebody can give me a chair, like a stool.
With the back or no?
No, it doesn't matter. It's fine. So, if I'm here like this, guys, so I have my belt on, I'm holding him here, and I'll say, okay, Pat, come forward. So I'm supporting his leg here, and I'll say, go ahead, and I want you to stand up. So as he stands up, I'm supporting his leg here. So I'm giving him protection, because if I didn't do this, his knee would buckle and he would fall. So one way to do it is I can use my hand to guard the joint, okay? And you could either go below here, and as you come up, and I can hold here and come back down. Some people will go right at the joint itself, right at the knee. Come on up. Hold. Okay. Other people will do this. They'll use their knee against his knee. So now watch my technique. So I know he's 5/5 on his right, but he's 1/5 on his left. So I'm taking him and I'm shifting his weight. I'm giving him cues to come forward, and then I'm giving him lumbar cues to stand up. And now I have 2 hands to work with, because I'm supporting. Try and buckle your knee. So I won't let him go down. So now I can work on facilitation up, weight shift, hold, and bend your knee a little bit, and back up. 1. So I'm getting that quad facilitation, and then come back down. So there's times when you're going to want to do that with your patient, okay? Address the upper extremity, address the lower extremity. And this is all from sitting. This is not even transferring yet, okay? So keep that in mind. Mike, any comments? Anything else that you would do?
In the hospital beds, they have like the railing that they can like really use the nerve damage. It helps them a lot with their balance.
Oh, to stand up?
Like if they're sitting up. from the bed.
Oh, yes, okay, right, okay. Yeah, that's a
Yeah.
good point, that's a good point. So when he's sitting, he has nothing to hold on to. So there's that thing of what's called unsupported sitting or supported sitting. So if Danielle and I are working together, so you come on over here. So let me have you get into the bed. So this is where Mike was saying, if Mike's working with another therapist, an occupational therapist or an OT assistant, the OT assistant or Mike would get into the bed or and be behind the patient. So now Pat is really weak. So he's going to be going to the side, and what Danielle's going to do is she has to make sure that he doesn't fall, so she's being his support, okay? So the rule is that, again, you don't want to use the patient's limb to pull on you, so you want to use the belt. You want to use the belt, and you can, now shift his weight. So she can do all that, and I'm here and I'm saying, take your arm and reach to me. One. So if I need to assist him, where should my hands be? On his left. But where on the body? Where on his body should my hand be? Shoulder. So I want to be proximal. I don't want to be down here and saying, okay, reach. Because I want to protect this joint, so I need to be here. So I need to be right here and sort of kind of approximate and say, okay, now can you reach over here? Can you reach here? So he's looking to his left side, he's paying attention to his left side. So his hemiplegic side, okay? Yes.
Couldn't it do that, like, if you weren't in that position, could it do damage because you'd be like sublux and trying to do it, or no?
Say it again.
Like, you know how you said, like, his shoulder would almost, like, sublux?
It would. It'd be
So then if you were
sublux.
trying to do it, it would just cause more damage, no?
By himself?
Yeah.
Oh,
No,
yes.
like, if you were like, okay, reach out for
No. Okay, so here's the question. The question is, his rotator cuff muscles are not strong enough to hold the humeral head in the glenoid. So if he were to lift, he's trying to lift while his joint is subluxed. Could have caused more damage yet. So what we do, that's why I don't want to be distal. I want to be here. So literally, when someone's sublux from a stroke, you can literally do this. Relax. You can literally lift their elbow and they're back in joint. And then you take your hand away, they come out. Lift, they come back in. So when I'm working with him, I'm going to be here. I'm going to be holding it, and as he reaches, I'm going to be kind of making sure that I'm helping him. Okay, make sense? All right. Now we're changing scenarios. Who wants to be a patient? Who? Debbie? Okay. All right. So Mike, come on over, if you don't mind. So Mike is going to be the therapist for Debbie, and Mike's job is to have her get her from supine to sitting, and then from sitting to standing and walking. Now her only deficit is, well, she has two deficits. One is she had open heart bypass surgery, so she has an incision that goes along her sternum. So there's certain things that we call sternal precautions. And then she has a little bit of weakness, but not much. She can still stand, she can support herself. So Mike is gonna instruct her on how to get up without damaging that sternal area. Okay? Because they split open the sternum, they put it back together, and then if you do certain things, you could cause it to reopen.
I don't have to do that.
So Mike actually does that.
I do? Oh, okay, no. Hey, how you doing? I'm Mike from Physical Therapy. Gonna get you up and get you moving today. Okay, maybe sit in the chair for a little bit. How are you feeling?
A little small.
A little sore right there. You know, you did have the open heart surgery, and you have some sternal precautions. Do you know your sternal precautions? Okay. Well, the first one, if you do not want to do anything that causes your chest to split. anything that causes your chest to stretch. I shouldn't say split. Stretch. You don't want to do anything that causes your chest to stretch out, and you do not want to lift your arms above your head, and you do not want to lift anything above 5 pounds in each hand. Okay? So the first thing we're going to do is we're going to try to get sitting at the edge of the bed, and you're very close to the edge here, so I'm going to ask if you can try to bridge over towards your left side. So bring your knees up, both of your knees. I want you to press down on the bed with your feet and move your butt over to the left. Good. Yep, and just keep going a little bit more. Right there. Okay, good. So, you can flatten back out. So the first thing we're going to do is we're going to roll onto your right side. I was like, can you bring just this leg up? Put your foot right on the bed. And this is going to be your drive leg. This is going to be the leg that's going to power your whole body over onto your right side, okay? So I'm going to take your hand, and you're not going to reach across, but instead you're just going to put it right on your abdomen right there, okay? So now I'd like for you to push down, into the bed with your left foot, and roll right over. Good. Okay, now you're going to bring both of your legs towards the edge of the bed. And you can actually bring your feet kind of off. Okay, so now we're going to try to sit up. Now I'm going to help you a little bit, but I want you to do as much as you can. And you are allowed to push down on with your right elbow, but I don't want you to push with this. Just put a little bit of pressure onto the bed and try to push, and I'm going to help you. Yeah. We're going to sit right up. Good.
Perfect. So you guys watch what Mike did. So he did it, and he verbally explained to the patient. So again, 50% of our job is to be an educator to our patient or their family members.
And I did that. I talked really fast. Like if I was in the room with him, I'd always ask him, do you understand what I'm saying? I'd go real slow. It wouldn't be that quick.
Yeah, and a lot of times the patient is weak and lethargic for no other reason than the medications they're on. And just recover from surgery. Also, there's usually a pillow in a person's room that's in the shape of a heart. And that pillow is used for self-splinting. Okay? So also, what Mike wants to tell her is that, you know, when she gets up and she moves around, she's going to be moving a lot of that fluid through. So
I have to get a block now, don't
yeah, just maybe 20.
Yeah, so every cardiac patient has a heart pillow that they give them, and what we as therapists like to do with that pillow is to try to get them to hug it when they're going to transfer. And what it does is it causes them to not use their arms, not break their sternal precautions, and focus on their legs standing or rolling over. Okay, so pretend this is your little heart pillow, and you would kind of hold it, and then They do allow us to use walkers with a sternal patients, but we're supposed to instruct the patients not to push down. If they're weak, then we won't use a walker because we know that they're going to push down a lot and they're going to put a lot of pressure on their incisions. So we usually just do like transfers, sit to stand exercise until they're strong and they're able to actually.
So you're usually going to be using a rolling walker with
rolling
them?
walker. Yeah. I don't like this. I mean, the only time I really use a standard walker is when they have a non-weight bearing. It's not functional.
Yeah.
So also when they use this, is they have to cough and they have to split, because when they cough, they're going to cough all that sputum and all that stuff out of their chest cavity, and that's going to be good stuff. Okay, good stuff. You want to document that stuff too, guys. Green, yellow, brown, whatever it looks like.
I'm fixing it.
Do their abs, I guess they
the
wouldn't
wheel's
really
gotta
be
be on the
affected,
outside.
Do their back what?
well, because like some of the abdominal muscles attach like on the sternum, but those don't get like affected much, do they?
Yeah.
They do.
Yeah. So that's why, that's exactly what. So when Mike got her to sit up, he did a log rolling technique to not use those ab or those chest muscles. Exactly correct, because it's more traumatic because of the way those muscles attach and so forth. So yes, that is correct.
It's a different kind of walker. I was trying to fix the wheels.
Oh, is that?
They need to face outside, but this
Yeah.
part's like
Does that work
stuck
out?
in it.
Does it do it? No.
No, I think I just can't get this piece out. They need to face outside,
Like that one is?
like that one,
Okay.
yeah.
Fix that one, yeah.
Should I go back to-
Bite
Well,
it.
if I push it in, it's not gonna, I don't wanna.
Go back to where it was.
Use your teeth.
Yeah, just put it back the way it was. It's just this piece.
Yeah. Well, it's better to be on the outside. Now,
You can turn it better.
the only time that you would have it on the inside like this, guys, is if someone lived in a home with a very narrow entranceway into their bathroom. So sometimes if you do it like that, it'll help.
That's you.
Rubber sounder.
Yeah.
So all our lockers have the different caps, so we don't have
Yeah.
that. So put the gate belt on.
Is that why you put the tennis ball in
Yep, to stop
Yep,
the
yep, exactly.
reduce the
there? Now I understood that. It's fashionable.
I know,
They
I
wanna
thought it
play
was
tennis, they're really good.
So again, guys, know where he's putting the gate belt. Okay?
The closer,
Away from
the closer it is to the hip, the more control you have over the patient. If you put it too high, sometimes it can go up into their throat. If you put it right here, then it could be uncomfortable, it goes up to their chest. I try to put it as low as I can, just because if you have more control over the hip, then you have more control over the patient. Okay? So then you'll hug your heart. Okay, and when we sit to stand for sternal precautions, we just want to make sure that they don't use their arms and they use their legs. So the first thing I'm going to ask you to do is, can you scoot forward so both of your feet are on the ground? Good. Okay, so the next part is you want to instruct them to stand only using their legs, and we do like a 3 count. So I'll grab here, and we'll say, okay, on the third, on 3, we're going to stand up. I want you to look up, or I tell them to, look at something on the wall, just to make sure they're looking up. So we'll go 1, 2, and 3. And then once we stand, they'll give me their pillow, and I'll tell them to put your hands on the walker. Now you do not want to push down into the walker. It's just there for balance. And if they start walking and I realize that their forearms are really tensing up and they're not able to walk without putting a lot of pressure into the walker, then I'll say, okay, let's not use the walker. Let's sit back down and we'll figure something out. So work on sit to stands or work on side stepping or, okay?
Okay, so that's sternal precautions, cardiac condition. You guys will see that a lot.
And also, throughout the therapy session, I will constantly bring up the sternal precautions. Okay, now that we're standing, and I'll actually show them, because when I'm telling them that laying down, it's not as effective as when they're standing and they're at my level and they can actually see. So I'll say you don't want to reach back, you don't want to cross your arms, to tense up your chest muscle. You don't want to lift your arms up in the air above 90 degrees, and you do not want to lift anything or push down, put any pressure. Okay?
All right?
The way he rocked back and forth before.
Momentum.
Yeah.
Absolutely. Absolutely.
Well, I need momentum to pick you up, because you're not, because the reality of the patient's never in that light. But the majority of our patients are geriatric population. None of them are going to do a sit-up. I'll tell you right now. I mean, very rarely you're going to say, "Can you sit up?" They're going to say, "80." Just the other day, I went into work yesterday for a couple hours, and I was working with this guy, and I'm like, "Okay, can you kind of sit up a little bit?" I'm like, "Use your abdominals." He's like, "Buddy, I haven't had abdominals since I was like 16." He's like in his 70s, so he's not. It's hard for them to sit up. You can still ask them, because some can. You never know. And it's going to be a lot easier for you as a therapist if they can do a sit-up, or you can have them start inching their legs together, and you can kind of facilitate a sit-up. But for the most part, just master the log roll, because that's really, practicality what you want to do. A lot of log rolls in the acute setting. I don't know about. I don't know the sniffs too. But.
Okay, guys. Kelly, you want to finish
Oh, that'd be fine.
Okay, all right. So now the next case is that we have Sean. He's our patient.
Patient Sean.
So Sean has he had a left CVA with right-sided hemiplegia. So he has to go from the bed. He has to go from the bed to this wheelchair, okay, and what's called a slide board transfer. Now, Dr. Walsh does not like the term slide board. She prefers the term transfer board. It doesn't matter, it's semantics. But essentially, you're going to be using this to teach the patient how to move from one surface to the other, okay? Because his right side literally does not work, it's flaccid.
The arm and the leg.
What's that?
The arm and the leg.
The arm and the leg, yeah. It's either flaccid or just maybe fast forward to 2 months and it's hyper contracted in the flexor tone pattern. In any event, his right side is not functional, okay? No. So, no.
Good thing I knocked when I spoke already. How are you feeling today?
Feeling all right?
Alright, so I just sat you up, so, are you dizzy, are you okay?
What?
You're fine, okay. So you're gonna be leaning to this side, and I'm gonna be trying to, you have a little bit of strength on this side. Right, did you say you had strength?
He has full strength on the left.
And what's his minimum on the right?
Well, no, like one.
One
One out of five,
So you're
yeah.
gonna be leaning to this side. Okay, so what we're gonna try and do, we're gonna switch you a little bit this way because I need to get the wheelchair next to the table. So we're just gonna rock you. When I rock you, go ahead and move your hip and we just rock you.
See that technique, guys?
Rocking.
Yes.
There you go.
So she's reshifting, rocking.
Backward, forward.
Yeah, I'm actually cueing his hips down and up,
Okay.
and then he's wiggling over. Is he doing back assist or is he doing the slide board himself? Or am I doing
You're gonna do mine.
it?
So remember, guys, the 2 points of contact when you're working with a patient is the scapula as one point, the hips as the other point. Okay, so those, you're gonna get the most facilitation out of a patient by putting your hands on those 2 points. Okay.
Okay, so we're gonna do the slide board. So this is your strong hand. So I'm gonna have you do that part. What I want you to do, we're gonna get the slide board on here, and you're gonna push this. So lean to your right, like that you, and you're gonna put that under. There you go. All right. So here's how this is gonna go. You're gonna take this hand and put it out. That's gonna be your leading hand. All right. But you're gonna look this way. So we're gonna rock this way, and on 3. You're just gonna push down with this hand and scoot this hip on the board. We're gonna do that a couple times. When we get to the wheelchair, you take your hand and you grab hold of that. Okay, are you ready? We're going this way. Ready? 1, 2, hold on. On 3 we go. You're ready to go, aren't you? Alright. 1, 2, 3. Now go ahead and move your hand down the board. There you go. 1, 2, 3.
You see how Colleen is guarding his weak leg? She's got control of his leg by putting between her legs.
3. So when you go over though, when you're gonna rock them, come farther down and over. I mean, it's hard to do when you're totally healthy.
Yeah. It's hard, but that's how you guys use the transfer board, and you guys will all have practice with that again. And to get back in bed, if you can lean forward and pull that out from underneath you, he obviously would have to be turned around to the other side to transfer back to his strong side. You guys follow with that? Very good.
You'd still use the board, correct?
He still used the board. Okay.
Their strong side is always leading.
Their strong side is always leading with a transfer board.
Just make sure with Dr. Walsh and Dr. Pitts too, you have to take the one side off and they like both the pennies off, so.
You're saying
You wanna, I mean, this side they're gonna grab it, you wanna make sure to take the footrests out whenever you're doing.
Oh, yeah, oh, that's what we do in the hospital. Yeah.
not just move it to the side, like actually take it off.
Right. yeah,
So
well,
Mike,
They wanna see it off and on.
whatever you did, just say, yeah, just do. So guys, another way you could do is in a hospital or nursing home or any place, you could put this on, okay? So this can help decrease the friction. Somebody can use this here, or you could take baby powder if someone does have an allergy to that powder, you can put it on there and that makes it smooth because it's their bare skin typically or the gown. Maybe it shouldn't be. It should not be. They should have some kind of barrier like the gown, but it doesn't always work out that way.
That wouldn't, like, kind of make it harder for, like, in the case of with him, whenever he was like using his hand to slide himself
He
over.
was a lot stronger than most people. He was going pretty easily.
Okay.
You would have
Well, I was
to-
just wondering because, like, if he puts his hand and it's not frictionless.
Well, you can pull it up a little bit, have him put his hand on the wood then. Just have the part where his actual gown would be, make contact with the wood
Okay.
on the sheet. But it's just one technique.
So he could put his hand here like this,
Okay. Yeah.
and then when he gets on here, so now his butt is on here. So now it's scooped this
Okay.
way. Yeah. All right. Now, you saw what would probably happen on a cardiac floor. You saw what happened on a neuro floor. So now this is like an orthopedic floor. So, Jess, why don't you be the patient? So you go ahead and take off your sneakers. Are you going to lay down? So what is this called? It's more typically called a boot than a shoe. It's basically to protect. Okay, guys, to protect. So you see how it opens up.
Is that for fracture stuff or something?
Yeah, we're gonna say that she had a fracture.
Is that in place of a cast, or is that after the cast comes?
This is typically after a cast has been removed.
Okay.
Where? Okay, so these are things that Mike and Colleen, these are things that everybody in the hospital has to be able to take off and put on. If she has a tib-fib fracture, so it affected both her tibia and fibula, which is the weight-bearing bone? The tibia. So the doctor has made her non-weight-bearing. She is 3 weeks after her incident. She went home, but she had an infection. She has a UTI. She has some stomach problems from taking antibiotics, so she's back in the hospital. She's still not awake. So the doctor wants us to still do therapy with her. So in the hospital, we can go ahead and remove, and we can do exercises with the permission of the orthopedic surgeon with her leg out of the boot. They will say boot and immobilizer on,